let me see if this atlas is free to move and this axis is free to move. If not, I'm going to find out which direction. So just come up towards me. Okay. So, for the atlas, if I want to shear it to the left, I take the head and I move it all the way over to the right. I take my hand, I put it right underneath the base of the skull, and I push in the direction to the left. I'll do it on this side. If I want to move the atlas, if I want to provoke the atlas to the right, I shift the head all the way over to the left. I take my hand, I find just below the occiput of the skull, and I push to the right. That shifts the atlas there, and at that moment I do my muscle test. If both of those are okay, I leave it alone. I go now to the axis. I put my hand in the first real vertebrae I feel with a transverse process. I push against it, and I ask the patient to turn their head to the same side. So he'll turn to the left, and that pushes the axis in rotation to the right. He relaxes, and I immediately test the arm. And if you can, elbow straight. The elbow must be straight. The elbow's bent a little bit, you're not ready. I then put my hand on the other side. I have it turn to the right, which pushes the axis to the left. He relaxes, lift up your arm, elbow straight, push, and that's it. If that is the case, he will turn to the right, and he will gently turn to the right, and I will move the axis to the left in rotation. If the atlas was the problem, I would shift him to the side of that made him strong, and I would push the atlas to the opposite side. And then I would recheck the suboccipital tendons and tone for abolishment. Yes. So that will help you with stuck axes or atlases that are just off and that are continuing to give upper cervical spine pain or discomfort or limit rotation. In the acute patient who comes in and goes, I can't turn this way, you will usually do all this, and you go, can you turn now? And they go, well, it's a little better, but it's still painful. They have facet inflammation that's not going to go away just because you've done this. So you will sit them up, and you will have to do, I can face that way, you will have to do distraction with mobilization with movement. So I will come here, I will put my hands here. If they can't turn to the right, I will traction them up, and I will help them turn to the right. I will look to the right, use your eyes to turn, because I am pain. Yeah, that's painful. Okay, come right back. Go again, nudge the pain, come right back. Go again, nudge the pain, come right back. Okay, now let's go in the direction that worked. And come back. And now I'll have you I'll go to the position of nudging the pain, and I'd have them try to turn to the left. And when they relax, I go to the middle. Turn to the left. And when they relax, I go to the middle. And then I say, okay, how is it? And he goes, it's a little better, it's still pain. Okay. I said, well, your homework is to nudge the pain to the right, or side bend with traction to the right. And I say, just chin tuck, do that, nudge the pain, it should improve. And usually it will improve. So You will not, when there's a facet irritation, you will not get dramatic restoration of range of motion because you've treated the patient. You will have treated them well, but they will not have a dramatic increase in range of motion because the facet joint or capsule inflammation is still going to be irritated and they won't respond well. But again, I would have done this, and even before the mobilization of movement, I would have retested my baseline to see if I had done the work I did. So there is no doubt in my mind that they are better, even if the pain itself is not significantly gone.